So welcome everyone to the second session in the Aged Care Virtual Education Series. Today's topic is early identification of cognitive decline. To start the meeting, I'd like to take a moment to acknowledge that we're meeting on the lands of many different Aboriginal nations across Western and Far West New South Wales. On a personal note, I'm on Wiradjuri country today in Dubbo, but I was fortunate to be born and raised in Wilcannia on Barkindji land. I'd like to pay respect to elders past, present and future and acknowledge their continuing connection to land, water and community and their role as caretakers of ancient stories and culture. I warmly welcome all Aboriginal and Torres Strait Islander Australians today and everyone present. So just a couple of quick housekeeping points. Please make sure you're on mute. If you could just pop your name and organisation into the chat box, that will just make sure that you're on our attendance record and that you receive a certificate for today's session. There's a Q&A at the end of Rosie's talk, but if there's a burning question that you have, please just raise your hand and unmute and have a chat with Rosie as we go. There'll be a QR code for the evaluation on the last slide, and we really ask that you fill out the feedback because we wait and read that after every session. And a reminder that today's session is being recorded. And lastly, Rosie has shared a copy of her slides, so I'll send those out to everyone when the presentation is over. Okay, so now I'm going to introduce Rosie. Rosie is Roseanne Murray, but she's known as Rosie. She's a clinical nurse specialist with the Aged Care Assessment Services, and we thank Rosie for being with us today. Over to you, Rosie.
Thanks, Erica. Yes, my name's Rosie, and I've a little bit about me. I've worked as a registered nurse for well over 30 years. I don't think I can actually put a number on it now. And I've had a history of acute, palliative and rehabilitation. I have been working with the aged care assessment team for the past 12 years and more recently as a clinical nurse specialist, and I work in an area where my key role is providing post-diagnostic support for people newly diagnosed with dementia. So I have a real passion for, raising awareness for this disease, and I'm just really glad that you've joined today to learn a bit more, because knowledge is power. So hopefully I'll share my screen right. You got that?
Perfect.
Thanks. Okay, so my presentation is on the early identification of cognitive decline. So in this, I'll discuss just basically what is dementia, the types of dementias, the risk factors, early signs of dementia. I'll go over the incidence and prevalence of dementia among rural and regional and remote people, the challenges for these communities, and how you can help as practice nurses and Aboriginal healthcare professionals. So what is dementia? So it's a term used to describe progressive impairment of thinking and memory that interferes with daily functioning. So if you think of normal aging, so as we get older, it's normal for our memories to change. These changes are a normal part of healthy aging. We might forget a name and recall or remember it a bit down the track. We might forget a movie or an event that you've seen and the name of the movie and you can't recall it. But we've given time and, a little bit of a prompting or a reminder, you can recall that information. So as long as it's in your, it's preserved in your memory in some way, people with normal, aging brains can remember that information. So it's different from dementia because those people can't recall that information as readily. So, for instance, with Alzheimer's disease, even if the information, you provide that information, you've repeated it, and then you wait and see, you give hints and cues, they just don't recall it, and that's called rapid forgetting, and that's not normal. So the key distinction between normal aging and medical conditions such as dementia is the impact on daily functioning. So with normal aging, our cognitive abilities change. Different functions, you're impaired a little bit, but we can still, function day to day and live independently. You can still make appointments with the doctor. You can still manage your medications. You can still shower, dress, and all those bits and those daytime activities that you normally have. As we age, sorry. Oh my God, I clicked too far ahead. Apologies. So with Alzheimer's disease, we know those differences. So the key distinction is the impact on function. So with normal aging, the appointments we can remember, and the meals and all those we can remember. So you don't have any trouble with that. It just may take a bit slower, but you'd have no problem with it. With dementia, it's the impact on daily functioning. So it's you'll see differences in where the memory and the forgetfulness impairs the ability to remember to take medications, to dress, to be able to drive. When those daily functions are starting to be impacted by memory changes, that's not normal. And so that's essentially what's the difference between normal aging. Normal aging, yes, we do have those changes in memory, but it doesn't impact your daily functioning. When you start to get a dementia or a condition that affects your brain, then it will gradually, over time, affect all those daily activities of living. And that's the warning signs that stick out for dementia. All right, so with dementia, so you'll often hear dementia is described as an umbrella term. So dementia is not a specific disorder. It's a condition with many causes. So when you think of with Alzheimer's disease is the leading cause of dementia in Australia, followed by vascular dementia. Then you have Lewy body dementia and frontal temporal dementia. So there are some dementias that are reversible, and those include, you might have an electrolyte imbalance, such as, low sodium, might have a deficiency in a vitamin such as B12. There's sleep apnea that can cause cognitive changes if it's untreated. Another one is hydrocephalus. So if they're treated, those causes of dementia, they're usually reversible. So if somebody has a sleep apnea machine, or it starts to improve cognition. And oftentimes when a client comes through the geriatrician clinic, one of the questions is, sleep, what's your sleep patterns? And if they identify that person has sleep apnea, they'll send them away to get that tested and then review their cognition again. So luckily there are some that are reversible, but often they're not. And as I said, Alzheimer's is the leading cause of dementia in Australia, and followed by those four. But as you can see by that picture, there's a whole heap of others and other causes of dementia. So dementia, as you probably know, is the second leading cause of death in Australia, with predictive data suggesting that it will be the leading cause of death soon. It certainly is the leading cause of death for women, which is a concern. So I've put the risk factors on in this presentation because it's something that you as health professionals, as practice nurses, you need to know this stuff. So you need, because these people will come through your clinics, and if you're aware of the risk factors and somebody comes in and they're lighting up with all these, you know that you need to keep an eye on their cognition, because they are a risk factor for dementia. So the prevalence of dementia globally is set to double, and I don't think we're really ready for it. They're making plans, but I can see, and you probably can see this now. There's a lot of people coming through for through aged care for an assessment, and there's a lot of people with they're either being diagnosed with dementia or they've definitely got signs of dementia. So age is considered the biggest risk factor of dementia, but it's not. It's not an inevitable cause of dementia. So even though, and that's the common myth of dementia, is that, oh, as you age, oh, they've got dementia. But it's not the key risk factor. Yes, it is a big one, but it's not inevitable. You can see a lot of people that are 100 years old and they've got pretty good memories. So research has shown that there are a number of modifiable risk factors. So the Lancet Commission, and that's that diagram that I've got there on the screen, in 2017 they identified that there were these modifiable risk factors. So they identified 9 at that stage, and they were diabetes, hypertension, physical inactivity, obesity, low education from childhood, and social isolation is a big one, poor hearing, depression, and smoking. So they were identified early on as risk factors. Since that original one in 2017, they've added 5 additional risk factors, and they are traumatic brain injury, and we're actually seeing a lot of younger people coming through who have been exposed to repetitive head injuries, sport and accidents and so on. And so they're more at risk. Somebody that has a traumatic, they're more at risk than somebody that doesn't have that. The additional ones were the LDL, high cholesterol, that was a risk factor, excessive alcohol intake, visual loss. Visual loss is actually a big one. And the last one was exposure to air pollution. So if you know those risk factors for dementia, it should help you identify people that are at risk. So that's why I've put that there. So the early signs of dementia. So there's possible signs of dementia, and some symptoms can be related to other causes and that, conditions. So, people present with, multiple chronic health conditions that you see. So a lot of these overlap with other things, but it's just piecing the puzzles pretty much together. So memory obviously is an early sign of dementia, but it's not necessarily an early sign for some dementias. So that's where it gets tricky, but it is major early sign. So if you think of normal aging and then those memory changes, so the forgetfulness, forgetting where things are, that could be part of normal aging. The thing that with memory is if they identify, there's things that person should really know, like it might be something that they've done a few weeks ago or a couple of days ago, and then the warning bells will be that they really should know that that's not something normal. So That would be the warning signs, when those little things are starting to creep in a bit more than normal. So forgetful and missing appointments, and forgetting key dates that they would normally remember, and difficulty retaining that information. So that's memory. Executive functioning, so that's your challenges in problem solving and planning. So your ability to cook, so to prepare a meal, or to manage your finances, or prepare a shopping list. If those things start to or there's mistakes starting to occur, then they could be possible warning signs that something may not be going right. Depending, it depends on whether that person was, managing those beforehand. Some people aren't very good with finances or whatever, but these are new. So somebody could previously do it well, but it's a change that's happened. Now, with all these early signs that I'm saying, they're gradual. So they don't all happen at once, and they don't happen for every person. So it depends on where the damage of the brain is occurring.
So for getting familiar tasks, so if someone is like I said, that they, we gave the example of a card player, and then from time to time that person's forgetting how to play certain rules, or the game, finding it difficult to navigate familiar locations when driving. So when those sort of things start to creep in, then we know that there are changes in memory, forgetting how to cook something that they've cooked forever. That's a sign. Confusion with place or time. So these are things that are easy to get for someone to hide, because they can say, if you're asked if what year it is, so if it's, that someone will say, oh, it's 2023, or, no, it's 2024, and then I'll go, no, oh, I don't need to know about that, or I'm retired now, I don't need to know about the date, and sort of blow it off. But there's obviously some things going on, and they'll use those excuses. Spatial trouble with gauging spatial awareness, so experiencing trouble navigating surroundings and performing tasks or coordinating movements. So walking up if you notice that somebody is a little bit more clumsy than normal, or they're tripping up or down the stairs. Another one where they could be, when they're driving, it's starting to, people are noticing that their ability to navigate their surroundings and even parking is becoming an issue. And these people were great drivers beforehand. They're just examples. I'm speeding through it. Language difficulties. We might notice this is in the early stages, as somebody, somebody's having a conversation, and then all of a sudden they'll drift out or lose track of what they're saying. Struggling to find words is another one. So familiar words, and they can't think of what they are. When I'm with the geriatricians, they'll often give can you name so many animals? And people just, they can't get, or, they'll name the familiar ones, dog, cat, cow, and they can't get past that. So it's word finding. Misplacing things, that's a normal one of aging, where we misplace things, but with normal aging we can normally retrace our steps and then find them again. Whereas with a dementia, that you lose that ability to be able to retrace your steps.
Hello.
Hello, what you doing?
Poor judgment.
Are you okay?
So more poor judgment than normal.
Did you have
Sorry,
for
Rosie.
somebody that, are we right?
Hello, everyone. Can you just mute? We're just getting some feedback. Thank you. Sorry, Rosie, to interrupt.
That's all right. No. So poor judgment would include things like, so somebody's becoming a bit more generous than normal. So So they're losing that ability to sort of filter those dangers. And so, you know, scamming is a big thing at the moment, and that judgment though is a big sign that we need to look out for. Social withdrawal. If you see people withdrawing from social activities and hobbies, you know, somebody that's normally very a social person, they're involved in all these groups and, you know, bowling and craft groups, and then all of a sudden they start to step back and make up excuses of not wanting to go. And that is not a normal sign for that person. And it's the worst thing they can do, because for anyone with a dementia, we need those social interactions. The changes in behaviour and personality is another one, where those changes in memory are causing agitation or those frustrations, because they're aware that these changes are happening, but they're not sure how to deal with it. And so it might become short fused. So somebody that's normally has those issues becomes, you know, anxious. So they're the common signs to look out for, and I've rushed through that and I apologise. There are other common signs though. So visual or hearing disturbances, hallucinations. So visual distortions, being, you know, seeing different objects. Visual actually is a major one. And so if people present and they go to their optometrist and there's nothing to explain why, that's a warning sign to, you know, that there could be something going on in their brain, whether it's a dementia or something else needs to be identified. Same with hearing, because a lot of people will get auditory hallucinations. So to get their ears tested, crucial. Restless sleep. So if you hear, you know, you have somebody come through your clinic and they're, you know, just you know that they're not sleeping well, or the partner says, oh no, they're thrashing around the bed all the time and stuff, that can be a very early sign of Lewy body dementia. So that's a big one to look out for. Another ones are those autonomic functions. So Parkinsonian features, not Parkinson's, but the Parkinsonian, you know, rigid, slow pace walking, constipation that can't be explained, postural hypertension. They're all signs, and they can be mixed in with other things, but it's good if you know that these signs are there. Then if people can't present to your doctor's office, then you know that, you know, that could be possible signs that we need to keep an eye on. So the next thing I wanted to really talk about was the incidence and prevalence of dementia among rural and remote people, because this is the area that we cover. So dementia is one of the top 5 causes of total disease burden and death in rural, regional and remote areas, particularly for women. And as age is the strongest risk factor for dementia, if you look around our area, there's a big ageing population. And, you know, with that predicted increase in numbers, which we're seeing now, it's crucial for the rural areas to have a plan in place. So there's a high proportion of older people, like I said. So there's 2 in 5, so 40% of people living in rural areas with dementia. And as I said, it's expected to rise over the next decade, and it is now. But with that predicted increase, it's concerning for us, because, you know, we have vast geographical areas to cover and the limitations. So a major thing to remember, and it's important, is that Aboriginal and Torres Strait Islander people have a higher risk of developing dementia compared to non-Aboriginal Australians. So it's 3 to 5 times higher, which is huge, and younger onset is more frequent among Aboriginal people. And why? Because they're exposed to, the risk factors for dementia. So, diabetes, chronic heart disease, the risk of strokes. They're exposed to those. So way more than us. So we just need to be mindful of that and overcome those barriers. That dementia is not a part of aging. It's definitely not, and that any change needs to be identified soon. And so with the remote, those regional and remote problems, we've got them here. So the challenges with respect to distance, location, transport, financial constraints, they're all deeply entrenched in remote regional locations, and they're not easy to solve or overcome. And when you combine these factors with the lack of health services and the lack of specialists and community services, rural and remote people, regional, rural, predisposed to poor outcomes. So we need to improve those outcomes, and that's awareness. So, and GPs and nurse practitioners, you provide a vital link in identifying changes in memory and advocating for a timely diagnosis, as you guys are usually the first contact. Now, there's a number of initiatives that, to try and solve the issues in these areas. One is memory clinics, and it's considered to be the gold standard approach to assessment. But unfortunately, it's a multidisciplinary approach, but unfortunately it's predominant in metropolitan areas. So one day, hopefully we'll hopefully find, I would hope that there's a mobile memory clinic that could go around the areas, but that's yet to be developed. I know there's possibility of a memory clinic being trialled in Orange, which will be a good thing. So our main aims are prioritising primary health. So that's our best bet at trying to capture people early with the signs of dementia. So education of general practitioners and practice nurses, so that in identifying those signs of dementia and acting quickly on them, it leads to better outcomes. So that means upskilling of practice nurses and Aboriginal health professionals. So education in terms of the screening assessments that we use for dementia. So your mini mentals, the GP COGS, RUDIS, the kicker COGS. So being, able to perform those and knowing when to use them with different clients is important, and knowing when to escalate. So and I'm not sure how the GPs, the hierarchy in the GP clinics, but at least, identifying that if somebody has cognitive changes, and then making, letting the GP know that you have some concerns, and, facilitating the referrals to geriatricians so that people do get a diagnosis, because diagnosis is important. So many times I hear people say, we've got a diagnosis of dementia. And you go, well, what type of dementia? What was the cause of the dementia? Because that informs how we approach the support. Somebody with Lewy body, it needs a whole different approach to somebody that has Alzheimer's disease. So it's important to know what the underlying cause of the dementia is. And, telehealth, with the one good thing about COVID was that telehealth became a bit more common. So we're seeing it used more and more, and it's starting to bridge those gaps in those outback areas, like Burke and Bree and all those. So we're bringing the geriatricians to those towns rather than having to travel to major locations to get assessments, because people just don't have the finances, they don't have the means of transport to get away, and they may not be well enough to get away. So telehealth has helped in those regards.
Rosie, just letting you know we've got 5 minutes to go.
Righto, this is the last one. So the role of practice nurses and Aboriginal healthcare workers, you guys have such an important role in the identification of symptoms of dementia. Because you see people on a regular basis, you can provide that continuity and consistency in care, building trust and rapport, breaking down those barriers of stigma and allowing people to be able to talk about, disclose that there may be something going on with their memory. Because you're seeing them all the time and doing those regular health checks, which are essential for anyone over 65 to do those cognitive screening. Have I still got you? Oh, you've got it. No, that was it. So that you can identify that. So that you can navigate care coordination. If someone's diagnosed or if they think they're diagnosed, then linking them to My Aged Care, getting them linked to services in a timely manner, getting that help, getting around them, providing health education and advocacy, for support. There's lots of help for dementia out there, so being aware of those and providing that information to your patients is so worthwhile, and bridging the gaps in access, provide culturally appropriate care in those Indigenous and rural communities. So it's better outcomes for your clients in the end.